Hi, welcome back everybody. As a reminder, I'm Carrie Smith, the clinical lead for Medic. I have the privilege to work with all the abstractors. We have nearly 50 abstractors at this point, and I have to say I'm incredibly proud of the presentations and the amazing work that they're all doing. It is vital, clearly, to this QI work, and this next section is going to be kind of fun. What we're going to be doing is focusing on 3 different case scenarios. These are actual cases. So in the course, they have a little bit of gray areas. So what we're going to do is Keith will get to the point where he will go ahead and review the case study when we bring it up. And then we're going to take a poll. Would you scan? Would you not? All 3 cases are focused on the head injuries, and 2 of them will be the adult, and then 1 will be the pediatric one. So what you're going to see is when we bring up the poll, after we quickly review the case study, you're going to vote yes or no. And then after that point, you should see, I believe in your, in the chat, you should see the Jamboard link. So you're going to be able to bring that up in a separate browser. And then you can, if you look on the left-hand side, there's going to be a little sticky note, shows you right in the instructions here. Just click on that. It'll pop up what looks like a sticky note. And then just put your reason why you chose to scan or not scan, and then place it in the appropriate spot that you'll see on the Jamboard. And we will do this same scenario for all 3. And then if you look up at the top of the polls, or when they come through, you'll be able to click at the top 2 to move to the next one or to the Jamboard. Okay, so we're super excited. So, and all of these case studies that we've done, as I said, they are actual cases, and I already know what the decision of the providers were, but we're curious to see how you would present this. And so after Keith goes through the scenario, or Michelle, and we do the polling in the Jamboard, then I will go through and show how the abstraction actually occurred and why. Okay, so we're just trying to do a whole tie-in together. All right, so we'll move to the first case study, and Keith?
Thanks, Carrie. We'll see how this goes. So I'm going to talk through this case, just highlight a few points here along the way, begin to formulate in your mind, this decision about scan or no scan, and also, a justification for that so we can discuss it using that Jamboard technique. Okay, so case number 1. We've got a 56-year-old man hit his head. There's some alcohol intoxication mixed in here in the history. Injury occurred this morning, so we're in the 24-hour window to consider using the Canadian head CT rule. Looks like he struck his head on a branch and caused a laceration. You can see a picture of this laceration in the screen there above his right eye. A few symptoms here: lost consciousness, reports drinking, in this case, 2 cans of beer today. Also has some other complaints of pain in his extremities. And then a review of systems that documents unable to obtain due to intoxication. I think this will be something that we're going to point out a little bit here along the way. So let's flip over to the other side of the screen here. We've got a physical exam. Interesting in the context of that review of systems, we have a normal GCS, Glasgow Coma scale of 15, no distress. The note of the laceration above the right eye, again, you can see the picture there. And then a pretty normal neurologic exam, actually really extensively documented, pupils, normal, reactive. We've got a neurologic exam. There's a note of some slurring of speech, but an alert patient. And you can see cranial nerves, sensation, strength, all tested, at least as documented, and normal. And then one note on a test result here, blood alcohol level of 312. I'll just sort of note that I feel like a lot of times the decision to scan is done before, say, that test result comes back. That may be an hour or 2 later, but, something to consider perhaps, I don't know, in the calculus around the decision. So why don't we launch the poll? And we'll see how people are landing on this along the way. I'll be interested to see how people think through. In particular, we've emphasized whether or not intoxication is not really part of the Canadian rule. We've talked about that at various points. Certainly, it may be a factor as people think about this along the way.
I'd also like to just remind everybody of the GCS, right? Because a 15 score means that they're opening their eyes spontaneously. They are alert and orientated to time, person, and place, and they are obeying commands. Okay.
All right. So, starting to come up here, and I'm seeing a bit of a split decision. Certainly mostly on the no side. I think that makes the coordinating center feel good. Yes. But still, a few yes responses. So let's move to the Jamboard, and I'd be curious to see where the justification is as people think about this.
So you probably saw in the chat, we did ask you to please use the stickies if possible. So if to the extent possible, please continue to use the stickies.
So on the one side, we've got scan and Y. On the other side, no. Certainly I see a lot of, alcohol as a justification. Predominantly on the other side, I think it's this GCS of 15. Carrie, I don't see anything else that you're seeing here.
No. And in this particular case, the provider who initially had done this real case did scan. So, all right.
Okay. All right. So now that you guys are used to the process, we're going to do the second case here. I'm going to move us along. Oh, no, sorry.
Oh, no, actually.
No, you got a debrief.
Nice try. Get a debrief. We're going to actually go through as to how this case was abstracted. Yeah. So if we can move to the next slide.
I might need some help because I can't advance to the next slide at the moment.
I can see it. It's tiny. We need a little bit bigger.
There we go.
Now we're talking.
All right.
Okay. So when we look at this, of course, we're using the medic provided tools. We're looking at the Canadian head CT rule. So, on the side, you can see all the red X's. Those are all the areas that the abstractors have to review for the documentation. So all that first series of like 7 answers or so were no's, right? That's a no in the abstraction. And by the way, this particular case study, this is all the pertinent information that was provided, right? So this is only what we can abstract is what was documented. So the one thing we did have, and we do note in the documentation, is that this patient was intoxicated, but we also put the GCS of 15, so we didn't have to use any of our proxy measures for this particular one. Okay. Now we'll move to the next one.
All right, my cue. All right, so might need another assist here to move to the second case. There we go. Okay. So another, of course, head injury case, adult head injury case. We're talking about a 58-year-old. This occurred at 1 p.m. today. So again, within that 24-hour window where you can apply the Canadian CT rule. The report is he was struck by a 2x4. The board was leaning across against the wall, fell down and hit him on the top of his head. A few aspects of symptoms. So no loss of consciousness, presence of a headache. Patient talks about being drowsy and nauseated at times, particularly in the first 30 minutes, and then began to improve. Didn't take any kind of medications beforehand, but didn't drink, reports drinking 1 beer beforehand. Let's flip over to the physical exam. So again, reported, documented, normal GCS of 15. There is note of a small red mark on the top of the head, but no breaks in the skin, no exam findings suggesting skull depression. And I'll flip back to the neck exam, but the neurologic exam is, again, normal. Normal pupils, a really extensive documentation of the neurologic exam here, alert and oriented, fluent speech, cranial nerves, strength, sensation, coordination, all tested at least and documented as normal. And then I think the wrinkle here, and the reason we want to bring this case up, is there is some neck findings, so some midline cervical spine tenderness, and some pain with range of motion of the neck. So let's launch the poll here. There's a couple different questions with this one because one of the things that we've talked about is a potential obstacle for following the rule is, gosh, there's some diagnostic momentum here. If you're going to scan the neck, are you just going to scan the head because of that? So we're going to ask if you're going to scan one, the other, or both, or none. And I'll just say too, we're not within MEDIC, the evidence basis around the reason to scan the neck, that's not part of what we are in the business of doing. So we're not going to comment specifically on the evidence of that, but certainly part of the question when you're confronting this as a case. All right, so waiting on the results here.
We see this kind of case quite often, actually, where it's like a potential dual injury. So, and of course, I always love in there, he drank a beer to help with his pain.
Sure.
These patients are so fun.
Never happens.
Never. A beer. Uh-huh.
All right. Here we go. Okay, so.
Nice.
We got a lot of comments about scanning the neck only. Certainly, I think if you're thinking about applying the nexus rule, probably makes sense. There's one case for just the head, and then a bunch of cases for, I think I saw both.
Yeah.
Went away fast.
27% that was doing both, right? So we've got at least, was it probably 80, 90% said scan, right? So only 12% said don't scan at all. Okay.
All right, so
scan low. Yeah.
Let's move to the Jamboard here and see some of the comments as to why
what's the
people
reasoning?
are making these decisions.
Yeah. There we go. Let's see.
Man, are those small.
I know.
Well, I chose to scan the head and neck. I'm kind of interested about that. Darn that alcohol. I love that.
That one beer thrown right in. See? Darn it. Oh. Can Megan or Anna, can one of you read that green one on the lower left just to see it looks extensive, and I'm sure there's great reasonings in there. It kind of
Oh. So that one is, I get that it's negative per Canadian head CT, but see, this is all the time at my site. Diagnostic momentum would lead to head and C-spine. Hard to explain the patient why only neck.
Sure. Yeah.
Yeah.
Yeah, it's interesting. I think when I was growing up through training, we oftentimes did x-rays of the C-spine to clear them. So I wonder if that could be something where you're not forced into, oh, I'm doing a CT scan, therefore I got to do the head. Doesn't necessarily have to be the CT of the C-spine. Perhaps you could think about an x-ray. Depends, of course, on the patient. But one way to think about that.
Yeah.
Okay, one more to read from the neck only. So it says midline tenderness, GCS 15, but reported confusion. So could scan based on improving in normal neuro. Don't feel that head CT is necessary.
Yeah.
Great. All right. All right. So there's some very specific points I'd like to make on this particular one, because again, this is also a very common scenario that we see frequently in the charting. So of course we have all the negatives below, and you'll see that I put the two top positives of the way that we would document. He did report a headache, and we do have altered mental status. Now for this particular one, we would not put that they had amnesia, because when you review his case from top to bottom, he is very clear on all of his moments of where he had alterations, timing, even how long it lasted. So there was no bouts of amnesia. He remembered everything during the entire space. So yes, he had moments of alteration, which we captured. And then he, of course, had his headache. But other than that, everything else was negative in his exam. So again, when we look at our CT head rule, there was no real indication that they needed to do that. I definitely, again, we're not addressing the C-spine issue on this particular one. And of course, in this one, he had both the head and the CT, the C-spine that were scanned. Okay, let's go to the next one. We're going to start with Michelle now, since this is our pediatric head injury case.
Thanks, Carrie. So like the other cases, this case was meant to have a couple of gray zones that we frequently see. So we wanted to kind of talk this out and propose it to the group. This is a 4-year-old who presents to the emergency department with a mother that apparently had an incident in the evening, summer evening, jumping on a trampoline. The incident occurred at about 7:15, but the presentation to the ED was about 10:40. So he was playing on the trampoline with a peer or his brother rather, and they were jumping, and somehow the brother's knee, impacted the child's eye and face and head. And supposedly at home, the child initially had several episodes of non-bilious emesis and a nosebleed, which had resolved by the time of arrival to the ED. Now, at bedtime for this child or beyond a child's bedtime. Otherwise, the history from the parent revealed nothing particular. The child wasn't complaining of a headache or any other complaints, and no visual problems. And otherwise, his review system was non-contributory. On examination, the child had a GCS documented of 15. The child was laying on the stretcher and was sleeping initially. And we have a little picture there of give you some context of what we're looking at. The head is described as some periorbital edema with some ecchymosis, but no raccoon eyes or battle signs or step-offs. And otherwise, the eye exam is pretty unremarkable. Everything moves well. The patient tracks well. He doesn't have any pain or limitation on range of motion. And his ENT exam is otherwise unremarkable. There's no hemotympanum or evidence of any kind of nasal injury. At any rate, the neuro exam is notable that they say the patient is arousable and answers questions appropriately. So despite the fact the child was sleeping, he's able to be awakened and evaluated, and he's moving all extremities to command. He does get a little cranky when he wakes up, and then he returns to sleeping when he's not being stimulated for the exam. So we're going to ask you a couple questions here because this falls into the intermediate risk head injury for children. We're going to ask a little bit about what you would propose to do in this particular situation. Very common. It's summer. This is probably all happening in our EDs right this second. So would like to know if you would discharge this patient, without a scan. Would you observe without a scan, or would you simply scan? And so if you can respond to the poll, that would be awesome. Yeah, we'll get the results here in a second.
Yep. And again, it's always
I'm still waiting for the results.
Yep. They're still thinking about it.
Here we go. Okay. So we have 4% of you who would discharge the patient without a scan. 85% of you would observe without a scan. Awesome. And then about 11% would still scan. So we're going to do the same thing we did with the prior two cases. We want to put up a Jamboard here. Now, just remember, we're going to have a couple different categories. So please put your sticky in the appropriate category. And we'll take a look at some of the decision thought process around here.
Everybody's getting a hang of that Jamboard now.
Yeah.
All right. Hopefully everybody's liking it.
Okay. Thank you. Okay. So for the person who chose to discharge without a scan, if someone could just read that, I just can't make out the writing.
So it says GCS 15, I'm vomiting, at home, but not while in ED. By time presented to ED, already been 3+ hours since incident.
Yeah, fair points.
Okay. How about the yellow sticky on that same I'm not sure if that goes in the right category.
So one of the ones on why they chose to scan is 10:40 at night, tough to evaluate. I can see this being scanned in the real world.
Okay. Yeah. And I want to just comment on that because I think there's a lot of situations where people, feel like, sometimes children are just hard to evaluate at the time of bedtime when they're already lethargic. But the point of this case is really to point out that we have some latitude here in terms of like taking stock of the objective findings of the case. If you have the latitude to be able to observe, that's possible. And I see the majority of the stickies are in that central category that is in line with what we know from the PCARN rules. So that's very helpful. And I can't read all of these, but
another one that might be interesting on why they chose to scan for you to comment on was, so they said, person says, I answered for what I've seen at my non-PED site. The expectation from the family would be to scan.
Yeah, so that comes in with some of the shared decision making. I sometimes, and I'm right there with you. I face parents all the time in the ED, and there are some that are just, really adamant that they, are pushing you to get the scan. I do everything I can to try to not do that, but given some of the circumstances here, I understand how that could still happen.
Yeah.
Someone wrote in there, observe until 01:15. That's interesting. So just in terms of like, how long do you watch somebody, with a head injury? So the original injury occurred at about 7. So that's probably about 6 hours, which is, pretty standard observation in many cases. So others said vomiting less than once, only real concern. I think this child vomited multiple times, but there was nothing documented on after the ED visit. That yellow sticky is so small, Andy, I can't read it. If you could just comment on it.
Moving this one out of this is actually an observed one, but I just wanted to make it big enough to read. So that was interesting. So this patient meets observation because of vomiting, but does not meet CT scan. One problem we find is that the patient meets for a trauma activation, then we have to transfer to a PEDS ED at the recommendation of the trauma surgeons.
Oh, interesting. Okay. Interesting. Okay. All right. I think a lot of these represent the spectrum of the thought process that go, on with while we see these children. So we're happy that majority of them are in that central category. So this is very reassuring. But the point of this case really was to get at what I think Andrea Millard was talking about in her presentation too, is that, really start to think about those isolated symptoms. And if you look back at the original rules and the subsequent studies from the PCARN rule, those with isolated symptoms of vomiting really still had a very low rate of clinically important brain injury. So certainly shared decision-making observation goes into that. So let's see how this chart was abstracted, Carrie.
Yeah. Couple good things to note on this particular case is I definitely see the parental issue with this. When we look at this particular one, with the mother reporting, that the patient was lethargic, but it was immediately qualified, this is past his normal bedtime, right? So in that particular, when we have that kind of qualifier, we don't say that there's lethargy, or that they're acting abnormally per parent, because they're not. This is their expected way to act. So again, when we're looking at all of our negatives, there's no physical sign of any type of skull fracture, hematoma, nothing like that. He doesn't have altered mental status. He's acting as expected. He did have vomiting more than once, but no severe mechanism. And again, to stress, per parent, he technically is acting normally. And again, when we look at these, this is an isolated symptom that he had only the multiple episodes of vomiting. That's the only thing we were able to effectively capture on this one. And so when we look at our PCARN algorithm there, he does follow under observation, which is appropriate. So, and again, this one was scanned. They were all scanned, just so everybody knows.
Yeah. So, I think this is really very helpful, from a overall just review of, there are gray zones in these cases, both in the adult and pediatric, rules. And certainly, all quality improvement. Our goal isn't 100%, but it is to whittle away at those areas in the gray zones that we can safely make decisions, for the benefit of patients when we're able to do so. And that's I think the stage at which we are at in Medic is now getting to a little bit of the harder stuff. That stuff in the middle now that we feel pretty confident in. We still have half the year to go. So, we are working on, particularly for the children, the intermediate risk head injury, and this is head injury time. It's summer and we're finally out there, thank goodness. So please take stock of these, as clinical champions, messaging it back to your faculty. It'd be, tremendous to, put a big push in and try to drive these numbers down a little bit more.
Yeah. And as far as the abstraction goes, we are fully abstracting based on what's documented. So we're doing our best to picture in our mind, as both Keith and Michelle have indicated, how they're thinking through it through a clinician. The abstractors are not clinicians. I am. So I kind of know where you're going so I can help direct them. But the point is we want the replication of abstraction. We want it to be able to any abstractor picking up this case should be able to abstract it the exact same way. And we follow all the same rules. So it's very important to look at the documentation and how things and what we can infer, things where we have a little latitude, but some things are pretty straightforward and we can only go based on what is actually documented. So just a note.
Okay, we just want to give people a chance to ask. Keith, did you have any comments?
No.
Okay.
Yeah, I was going to say questions.
Yeah. So we realized this was a lot to digest in a very short period of time, and probably you were so busy trying to answer polls and questions. In the Jam, put your comments into the Jamboard. So we hope you appreciated your ability to interact with us. But let's open it up to questions and see what questions you have out there.
Currently, there aren't any in the Q&A. I did see a couple people try and raise their hand. So if you do have a question and you want to put it into the Q&A now, that would be a great time. In the meantime, I also wanted to mention that this could potentially be used as a teaching tool. So if there are folks who are interested in using these cases, please let us know and we'd be happy to facilitate that.